So welcome to the couple of hours, if you like, on kinesiology taping. Has anybody done this before? Anybody had a dabble, had a try? Yeah. Yeah. Okay, so it's been more of like an intro. Yeah. Obviously, I'm going to focus more on the lower limb. It's normally a one-day course that I would do, and then we would cover probably about 18 different techniques, starting on the foot and then finishing typically on the tennis elbow and wrist, yeah, and things like that. So I presume you're all podiatrists? Yeah, so you're all specialists in because I said to SJ, what's their anatomy like? And she said, they're going to be amazing. I said, perfect, because I'll be testing them shortly. Yeah, I won't really. But I'll ask you some questions to see how you get on. Yeah, but I don't then tend to specialize on the feet as such, even though it's sort of my area in some respects. I'm an osteopath. I've been an osteopath for 19 years, I think, something like that. And before that, I was a sports therapist, and I was in the army as a physical trainer. So exercise was my thing, yeah, in the army. And then I went to sports therapy, and I was a bit bored of that. So then I went to the osteopathic side, and I was a bit bored of that in some ways. So then I'm more lecturing and writing books now. So lots of my books are next door. I think I've done sort of like 8 with 2 editions. Yeah, so I'm doing a spinal book. I'll probably do one on ankle and foot, because people keep saying to me, oh, you're going to be teaching ankle foot courses. So I sort of add it in when I do a knee. So I tend to include a little bit, because not many people tend to do it, if you like. So we will see. First question. Let's see how you get on with this one. So there's a technique using the white zinc oxide tape, which I presumed you're all utilizing, trained on, sort of, yeah? There's a technique for plantar fasciitis, and it's called the low dye.
Or high dye.
Okay, or high dye. Okay, so where's it originated from? Who named it? Second?
Wales. It was Dye.
What do you mean dye?
Dye was the name of the practitioner, was it not?
Do you know his name?
I can't remember his first name, I'm having a blank.
Yeah. Well, his name is Dr. Ralph Dye, who was a US podiatrist.
Was he US?
Yeah, and so that's where it's originated, because a lot of people think dye sounds a bit weird, like low dye. Yeah, so low is obviously relates to the foot, and the dye relates to his name, yeah, Ralph Dye. And then the high dye, do you know what that one is? Because you mentioned it.
Basically, it's low dye, but it's similar. It's just comes up high up the ankle.
Yeah, so it's more of an ankle stabilizing technique. Yeah, so because lots of people, when I'm teaching podiatrists on K-tip courses, they've never heard of it, and I was like, and it surprised me a little bit. It seems it's originated from your sort of profession. You're all familiar with how to do it with the white zinc oxide tip? Yeah, and it works really well. The problem is, what do you think the problem is with using that type of tape? Second? Yeah, it depends on the foot, I would say, and also men with hair. It's a bit debatable whether it sticks or not to the hair. Yeah. But sometimes the problem is you don't tend to leave it on for that long. When I used to do it, let's say when I used to look after Reading Rugby, and one of the guys, and the only technique I knew at the time was athletic taping, because it was like the in thing. Yeah, so that's all I would use. Then I've been trained in McConnell taping, if you know that name. I'm teaching that tomorrow on knees and shoulders. Yeah, and then there's another taping system called PowerFlex Power Tape, which is from a US athletic trainer called Ron O'Neill. So that's another taping system. And obviously we've got the K-tape, which originated from Dr. Kenzo in 1973. And he was a Japanese sort of chiropractor. So there's 4 different types of taping. With athletic tape, because you only leave it on for maybe the game, yeah, or maybe an hour or 2. And also when you apply the tape and you ask a patient to walk with the low dye technique on, yeah, in reality, it doesn't allow the foot mechanics to go through its natural pronation, because it restricts and supports that medial arch. Okay, so it's almost restrictive. With a sock on, shoe on, it's okay, yeah, and it's relatively comfortable. But then if you've got any twists on it and you want to run, yeah, then obviously running would be relatively difficult, especially if you're a heel-to-toe sort of runner. So when we use the K-tape application, it would be very different. So the K-tape is almost debatable in how it works in some respects, because with athletic tape, and let's say you're trying to stabilize an elbow and a patient has pain in extension, then you'll probably tape them in flexion. Okay, it's like an Achilles tendinopathy. So when I used to teach Achilles taping using athletic tape, we would normally place a foot into plantar flexion and tape it. So we try to limit dorsiflexion. But trying to walk and run is relatively difficult-ish. Yeah, you know, if you've got to run a half marathon and you've taped them in plantar flexion, okay, they'll be almost ripping off within probably 10 minutes because it restricts the motion. Whereas with this tape, it is probably more of a placebo effect to a point, whereas athletic tape is definitely a physiological response because you can see how it works and it does restrict motion. So if you've got an elbow pain and you restrict an extension, you can see it works. Yeah. Whereas with a K-tip, because we have something like 120, 140, rock tape says Veya tape is about 180% stretch. Okay, so we have lots of stretch. When we apply athletic tape, we normally will sort of like apply the joint into like a not restricted position, but we try to limit the motion within the joint. Whereas when we apply the K-tip, we normally take that joint range to end range because we want to apply it in function. Okay, so like for instance, when Ron O'Neill taught me about dislocated shoulder, when I treated dislocated shoulders in rugby, typically that athlete is probably not going to be playing for that season. Whereas Ron O'Neill said, well, we spent $10 million on this guy. Yeah, we need him playing next week. Okay, so then they would literally use all this strong tape. It's not really athletic tape, it's a different system. It's like vet wrap if you look after horses. And it restricts motion. It's almost like a plaster of Paris when you look at it, because one tip fixes to another. So you would limit external rotation like in an abduction. So you basically stop in that movement. So you allow this full range, but you would stop them in that one. Whereas the K-tip wouldn't work like that because we would probably tape the shoulder in full external rotation rather than taping in, say, half medial rotation. Okay, so it tends to work. So because it doesn't restrict, patients will sometimes say, well, how does it work? And how do you think it works? Any ideas? Have you read anything? Because the research is positive in some ways and is negative in others. They're about sort of like 50-50, depending which ones you sort of read. Any ideas? Because if you look in your book, so the book is for you. There's a little bit on page, so if you look on page 20, what is it, 20? 19, well, let's start with page 19. So this is your book, you can have a read, because I don't be spending hours just on like the theory behind it, otherwise we won't get to do any practical side of it. So if you just look at a simple inflammatory response, it doesn't matter whether you twist an ankle, okay, or whether someone hits the side of your leg, or whether you stick a pin in the skin. Okay, the body is typically going to go through an inflammatory response, okay, where you're going to get redness, heat, pain, yeah, swelling, loss of range of motion. You're all familiar with the cardinal signs of inflammation, yeah. You know, if someone hits your leg, you know, you might have like a hematoma, like intramuscular or intermuscular hematoma. Doesn't really matter. Okay, it's just swelling. Lymphatic fluid it causes swelling. Swelling causes pressure, irritates the nociceptor, and then before you know it, you've got pain. Okay, so swelling causes pressure, pressure causes pain. And the typical way of trying to reduce swelling, apart from taking maybe anti-inflammatory, yeah, would be by the usual, the rest, the ice compression and elevation. Yeah. But then if you turn over the next page, like Kenzo thought, well, rather than trying to restrict the motion to the tissue, he decided that, well, if we are able to somehow cause a mechanical lifting, and rock tape call it the biomechanical lifting mechanism. So the idea is that if we've got tape and it's got this natural stretch to it, and we apply the tape to the skin, okay, in a certain way, then because it's like a coil, and as you pull it, let go, it causes like a recoil to that sort of tissue. You won't see it. You'll see it in the book I've got next door to show you, the rock tape book, which is like power taping. And on there, they've got a t-shirt and they've got a bit of tape on it, and you can't see any difference. But if you turn it over and look on the inside, you can see it's almost like convoluted. It's like, yeah, part, yeah, I think so. Yeah, yeah. So it causes like a convolution to this, or like the epidermis. Even though you can't see it physically, that's what they reckon happens. It causes this microscopic lift in. So the idea of that lift is cause a space, and then the idea of the space will be to allow the lymphatic fluid to then drain back. So if you have like lymphedema massage, then you might find it helps. Yeah, but you might find it takes some time to do that. And it's very slow and it's very light. Okay, because most sports massage therapists would almost like miss the lymphatic system to a point because they're almost like using their thumbs and their elbows and things like that. So it's too deep the pressure. Whereas if you see a lymphatic massage specialist, yeah, then it's almost like so light and so slow because they're just trying to work on that lymphatic system. So the idea is if you've got tape on, and you leave it, not for like an hour for the game, but you leave it for many days, 3 to 5 days, then potentially it has more of an effect because it is working whilst you were sleeping. So Kenzo says 3 to 5 days would be optimum. Yeah, but after 5 days, you would then take it off, maybe have a day or two to rest, and then you would then reapply the sole-like tape. And that would be one physiological effect, if you like, of how the K-tape would work. But then towards the back, if you turn the last chapter, where you see the fan-in taping, you can see that one? Yeah. If you looked on on Google and you put, say, K-tape for edema, yeah, or for hematoma, or for bruising, or for this, or for that, there are many, many pictures on there where you'll see the fan-in type of tape in over the hematoma, and then like 2 or 3 or 4 days later, you remove the tape, and you think, wow, I can see the definitive lines of where the tape has been applied. Yeah. When I've done the ROC tape level 1 and level 2, you know, and obviously I'm linked with them, they sponsor me. So I've done their courses, and I quite like the way they teach it, because on the PowerPoint, it was my friend Daniel who was teaching it, and they simply said, when you see the picture of a fan around the area, it doesn't matter where it is, if it's on a shoulder or knee or a forearm, yeah, it's almost simple. They said, we don't really know how this works. And I thought, that's great. Yeah, at least you're honest. You're not trying to, you know, reference this and reference that. And at the end of the day, they said, they don't really, you know, and ROC tape is originally a taping product. So all day, every day was about tape. Like me, today I teach K-tape. Tomorrow I'm teaching the knee, the next day I'm teaching the hip, the next day I'm teaching spinal. So I only think about K-taping, yeah, when I do it a little bit, which I don't much anymore with patients. I don't see many patients. I'm too busy doing other stuff. Mainly on my motorbike on the dirt, that's another story. And other times then I'm focusing on my new book on spinal manipulation. So K-tape is a small part of my life. Yeah, whereas for ROC tape, it's a huge part, because that's how they make all the money. So they spend all the time researching it, yeah, trying to see, you know, what works, what doesn't work, etc. When I wrote my book, there was about 60 different types of tape. And I think I wrote that first edition in 2014. I got another edition somewhere, which you're more than welcome to have a look at. Yeah, so this one here. So this is a second edition. So it's all that you got in there, but with some more techniques, self-taping techniques. In terms of the referencing, there's probably not that much difference. A few extra ones, but not really. So that's my second edition. The first one, you've got all the DVDs. These ones work with the QR codes. So if you're interested in any of the techniques, you can use your phone and go click, yeah, and then you can find them that way. So people like that. Everything is on YouTube. I've got something like 400 videos on YouTube of all these techniques. So if you're not sure how to do it and what I showed you, then you're more than welcome just to go there and sort of like and watch it. Now, when we get to the ankle, when I tape ankles, okay, which which I've done lots of in my time, especially like being in the military side as well. The K-tape will work to a point, but because we have that natural stretch, it doesn't give you the stability like the athletic tape would. But then what I've done, I've modified the techniques. So if you think about this logically, if you've got the stretch of a tape and you take out the stretch and there's no more stretch possible, then that's going to give you more stability than you would if you applied it with half stretch, okay, because you've got this 50% extra stretch. So if you're going on your ankle and then you're going over, okay, so what would be the most common injury to the human body in terms of sports-related injury? Inversion sprains. I mean, ligament would get damaged? Yeah, so the ATFL. I know you know. Yeah, yeah. Remember, I'm asking the rest of the group, okay? So ATFL, so what does it stand for, do you know? Yeah, so the anterior talofibular ligament. The other ligament that tends to get sprained as well? Which one? The other ligament. So you got ATFL, and then you got the...
No idea.
Which one? Okay, and another one? So if you think about the three ligamentous complex, the lateral sort of side. Yeah. If I said CFL? Yeah, so the calcaneal fibular ligament. Yeah. Yeah. So the majority of the ligamentous sprain, okay, will be to the ATFL. So when I show you the tape which I've modified, I quite like that one because we tend to put two sort of like tapes and they act as a sort of like a stirrup. And then we can vary then what we can do underneath with like a heel lock. So I'll show you a couple of variations for that one. So my plan was to show you one for like a plantar fascia. Yeah. That is, if you look on, say, YouTube for K-tape for plantar fascia, a lot of them will be the fingers. Okay, there's like 5 fingers which go underneath the foot. And when you look at it, you think, wow, that looks amazing. But as soon as you put your socks on, it's not going to be like that, because as soon as you pull your socks on, each finger peels. Okay, and it doesn't really do what it should do. And it doesn't really provide much stability. It's more of almost like how it looks rather than how it feels. You know, people are almost going, oh my God, that looks amazing. Oh my God, my foot feels so much better, because they convince themselves it's actually working when it's probably not really working. Whereas if you've got a different way of applying the tape with a bit more stretch and it gives you a bit more stability, then you might find that should work better than maybe the finger, okay? So when you think about the patients that you see, and they've got a true plantar fasciitis, so where would the pain be with a plantar fasciitis? We have a skeleton there, but in terms of anatomy,
Which one though?
huh? Huh? Okay, well, yeah, so the typical area. Yeah, so the medial calcaneal tuberosity. Okay, so that's where the majority, if you like, of plantar fasciitis would relate to. Yeah, obviously many reasons for. Yeah, it's hard to say exactly, you know, there's no one reason, yeah, for that, you know, because most of the population, according to podiatrists, tend to pronate. Okay, so you can't say because you pronate, you got this pain. You know, it could be lots of other reasons, yeah, around it. You know, like in the military, when I was in the military, lots of men would have this. Then you're 16, yeah, you've just joined, you're not used to running. You're very not used to running generally, and then you got things on your feet like boots, okay, and then you got things on your back, yeah, like weight, okay, then you have to go up mountains, okay, and things like that. So you wonder why, you know, a lot of the and then they get shin splints as well. So we can discuss that as we go through. But yeah, so you tend to get pain within that sort of area around here. So that's the medial side of the calcaneal tuberosity, yeah, around there. We can also look at where the Achilles comes in here. So this sort of area around there. So we can do one sort of taping for that. It's conjoined with an Achilles one, yeah. But then you can also modify it. So if you've got sort of heel pain, you know, on a child who's maybe 8 or 9 years old, and they've got sort of heel pain, what condition could that be? Stop it.
No, it's not. There's no such thing as severs.
What is severs anyway?
Calcaneal fasciitis. We don't use the word severs.
Okay. Who's sever?
I don't know my severs.
Okay, yeah, it was named after James Sever, who's an American. I think he's a surgeon. He was, yeah, but it's called calcaneal or fasciitis calcanea. Yeah, so would it be a similar thing to on a knee? What's a similar condition to the knee, but in a teenager? Yeah, so an Osgood Schlatter. Okay, yeah, so I'd been Robert Osgood and Carl Schlatter who named that one around here. Yeah, so if you've got sort of like pain around that sort of area, yeah, then you could call it. Is that what you would call it? So you wouldn't call it, the nickname would be severs.
The reason we don't like use, or the reason that the children's podiatrists, or a lot of them don't like them, is that A, it's not a disease.
Yeah,
so it makes it
no, true.
Inside, and secondly, it's a prominence, so it means fuck all. So if you're using it, it catastrophizes it for the patient, and it also makes it doesn't actually refer to anything around it. So that's why they tend to prefer calcaneal.
So what would you call this one then?
So just put tibial tuberosity.
Okay, so you wouldn't call it Osgood Schlatter.
That one's a little harder to do, but then again, Osgood Schlatter isn't a disease, so it's not so severs disease.
Yeah. Well, it's still an apophysitis.
Yeah.
Yeah. So you can call it that. Yeah.
So no, it's just avoiding this language.
Yeah. No, exactly. Yeah. So you can have some pain. So you can use some taping. Yeah. So it'll be a similar way to what we do with the Achilles. Yeah. And then if you've got time for anything else, we can, you know, like a shin splints or things like that. Yeah. So so I think we'll start on a plantar fascia before we move on to the practical side. Do you have any questions before we go on? Because a lot of information is in the book anyway, and you know, you got my leaflets there, and you got my cards. If you have any questions, you can just send me.
Maybe asking something stupid, but the zinc the white tape.
The white tip, zinc oxide.
Yeah. Tend to use
Leukotype. Leukotype P.
Yeah.
The brown one.
Yeah.
Yeah, that's good. Yeah.
The problem with the brown one was you find that you can get a reaction to them.
Yeah. Zinc oxide.
Yeah, you get it.
But all of that, those tapes you can, I suppose, but there's such a lot of tapes out there as well. There's only
You're all
one.
good
One
old-fashioned brown zinc oxide. Oh God, because I did. You just reacted.
Not had many reactions
I
recently.
think it's almost.
Yeah, no, if you use a brown Leukotape, you normally have a fixamol underneath it.
What?
A fixamol. So there's like I've got some, I got
Some more.
a fix-a-mole is like a micro pore. So if you do, say, the Leukotape on the shoulder, and then you'd probably over the knee, then you put the white porous tape to protect the skin, and then you put the brown tape on top of it to protect the skin from it.
Right. I mean,
Yeah, if you're using Leukotape P.
MSK, and that's part
Yeah.
of the reason why I'm here as well. But there's a lot of tapes out there that are absolutely awful. I don't
Yeah.
know whether-
Yeah, whereas K-tip is rare to have a reaction to the K-tip because it's hypoallergenic and is latex-free. So we tend to,
One in the last
yeah,
year.
it's rare. I've had one on the shoulder, Yeah. and I've probably taught more therapists than probably most people, yeah, in terms of the K-tip. So, and naturally they're going to email me. The problem you've got with the tape, if you spend in a bit of money, like there's a tape called KT tape, and you can buy it in Boots, but it's for exactly the same size, 5 meter by 5 centimeter. It's £22.50 for one roll. Rock tape's about £13.50, but then I've got a code called, it's like JGBM, so John Gibbons Body Master. You get it at 43% off. So it's about £6-7, which is a lot better. But you can't buy, from eBay for £1 or £2. You can go to a pound shop. The problem is if you're using that type of tape, yeah, then one, it doesn't stick out well because that's what most athletes would say. It doesn't stick very well. Whereas rock tape have like a H2O version where they've got a bit more adhesive acrylic laid down. They've also got like an RX, which has got a little bit less, yeah, for maybe the person who has sensitivity issues to the, say, the foot, yeah, or they're a bit old and the skin's a bit frail. So they do different variations, which is great. And if you have a problem with the rock tape, you can contact them directly or contact me. So it's no problem. Whereas if, yeah.
See, like for a lot of the patients that I see, maybe older, maybe got dry skin. Any issues there? Is it okay? See if you've got. I'm just thinking at some of the patients.
Yeah, you could try the less. You can try the RX tape, which has less acrylic laid down. Okay, so it might not stick so well, but it's worth maybe trying first, or once, and then if it's okay, stick with it. And if it doesn't stick that well, yeah, then you can buy like a spray. But I suggest you don't buy sprays. It's like when I did it for athletes where they'd sweat. Okay, it's almost one tape on damp tissues, doesn't stick, nothing sticks. Okay, so you can dry it and you can use like a kind of tough skin. Yeah, it's like, I think it's a Muller tough skin, there's a product. So you can spray, and then it's sticky, and then the tape will stick. The tape of K-tape works better if it's directly applied to the skin because it should be working on that skin layer. Yeah, if you've got glue, so you've got like the tape, then the glue, then the skin, then you've got a barrier in between. Okay, so I suggest we don't use sprays. But for the, if I looked after a rugby team or football team on a regular basis, and they were, they said, "Oh, can you just tape my knee up if I'm sweating?" I'm not going to say no. Okay, then I probably would spray and play a game, and I probably would take it off afterwards. Whereas if you treat an AP, let's say you're treating a plantar fascia, whichever method you do, and then you think, "Oh, I wouldn't mind," they say, "Well, what about tape?" I've looked at tape, and I say, "Well, I can do some tape for you." Then you can like cleanse the skin, apply the tip, and leave it on for 5 days, and then say have a day or two rest, give them some exercise in between, and you can shower as normal. Yeah, it shouldn't cause a problem. There's no real contraindications. You probably wouldn't go over varicosities on the leg and anything that's untoward. But for most skin, then you should be able to apply it. Men with hair, sometimes we would just trim it a little bit rather than shaving it completely. Yeah. Yeah. So, but then it does seem to stick okay, not brilliant. Yeah. Whereas, when I looked after teams, I would normally say to the men, from where I'm taping the ankle, from there down, there's a razor, off you go, shave it. Okay. Then it saves you using the under wrap first. Whereas lots of the men would want the under wrap just to protect the hairs. Okay. So, if you've done that sort of sport, you sort of understand. Whereas with K-tape, it doesn't seem to cause too much of a problem. Yeah. Okay. So, so we'll start with, can I use your foot? Okay. So let's say, for instance, you've got pain around the area and you've decided that it is a plantar fasciitis. Okay, might not be, but let's say we treat it accordingly. And then you've decided to use some of the tape. Then this is how I would apply it. There's many techniques. If you looked at YouTube, it's probably 5 to 10 to probably 200, yeah, depending. So this one tends to work for me. I'm not anybody come back saying it hasn't really helped, which I quite like, because if it doesn't work, I normally modify and change it, yeah, and things like that. But I must have done this thousands of times, yeah, and teaching it, things like that. Now, what Kenzo says is that we would normally, like for instance, if I was doing a low dye taping technique, then I would probably tape a foot in relative neutral. And so I would use the zinc oxide, but in this case, we are going to apply a dorsiflexion. So we are what they call preloading. So rock tape will say we would preload the tissue. So we preload it, so we place it into a stretch and we apply tape over a stretched tissue. Because when you think about, say, an athlete who's going to, say, it doesn't matter whether they're going to throw a javelin, okay, or kick a ball, okay, if you restrict the motion, so if I tape the shoulder with athletic tape and I limit external rotation and abduction, then I'm going to limit that athlete during his activity. Because the word rest and the word athlete, they don't really go together. Okay, whatever you say to the athlete, you say, well, you want me to rest? I can't do rest, I can't rest. Okay, so, you know, they will be doing something, and if you don't advise them accordingly, they'll probably go and see someone else. They said, you know, can you not just tape me and I can still play or train or this or that? And you go, yeah, okay, I'll probably modify the tape for you. And that's what I mean. So you don't want to be restricting motion. Okay, so we'd almost take the limb to the point which is required in the sport. So in this case, because when we're walking, we want to be lifting the foot up. So it's going to be dorsiflexion. We don't want to be taping it in a plantar flex position. Okay, so we are preloaded. Then when we apply the tape, it's called the stabilizing. And then we normally apply a smaller piece of tape. And then that would be known as either the pain relieving strip or the decompression strip. Okay, so rock tape say we preload, we stabilize, we decompress. So it follows the three, but then we do modify around it. Otherwise, each technique would be similar. Yeah, and I try to vary it for each one. So in terms of the tape, on the back of some tapes, okay, rock tape for some, but not many, there are like squares. So like 1, 2, 3, 4, 5. I think that's 5 there. So 5, like a 5 square, okay, I think it's 5, 1, 2, 3, yeah. So a 5 square would be a typical, what we call an eye strip. And you would get 20 of these at size 5 within one box. Okay, that is normally what you would get. But on some of the tape, the rock tape, you might not see the squares. So you'd almost have to roughly take that sort of measurement, along there. You can do the measurement if you want to. You can almost like go from the distal part of the foot, just sort of like, probably a quarter of a way up the lower limb, around that sort of area. But when we put stretch onto it, it's going to go a little bit further. Okay, so, you know, if your tape has the squares on the back, you look at the rock tape ones, the one you got, and probably they just have like motivational comments and jokes. Now, place one bit of tape over it, so you fold it, and just trim those ends. Any ideas why? Yeah, so when you apply it, you know, when you put the socks and shoes on, but, you know, if you're rubbing it, say, or drying it after a shower, and there's a corner, it will peel, and if it peels, it's going to peel off. Okay, so whereas if you round the end, so that would be a pre-cut, if you like, now. Yeah, so if you bought the KT pre-cut tape and you pulled one bit off, it would look like this. So the ends are rounded, okay, and it would be this size, and you get 20 of them in a box. The problem is with pre-cut tape is that when I looked after the boat race team of Oxford, they were between 6'2" and 6'9" tall. So if I'm doing their hamstring and I'm using a piece of pre-cut tape, then it's not going to work for them. Yeah, so I need to design it, if you like, for them. So I'll use my.
Yeah.
Well, athletic tape. So I'm going to say how you do that. Yeah. Yeah, I was going to say, how do you cut the ends on that one? Yeah? You'd have to show me that one. Okay, so I've got 2 bits on there. The colors are irrelevant, okay? So it makes no difference what color. But it's amazing how people smile, you know, when you go, you know, when you say, what color would you like? I go, well, what color have you got? And I go, well, I got pink. And the girl goes, pink? I love pink. I love pink. Yeah. Whereas some of them, they're like, oh, I don't like that color. Like the tan color seems to be not very popular. But in clinical sports medicine, it's one of the most popular. Yeah, because it sort of like blends in with the color of your skin. And if you've got, say, you've had a mastectomy, and then you've got lymphedema in the arm, and then you wouldn't want any colors in your arm if you're going to, you know, to the supermarket. So to have a light color, but skin color, just blends in, and you wouldn't really see it. Okay, so it's, you know, it's more appropriate. So from here, we bring the foot in this position. You okay with that? Yeah. Yeah, because it's not going to cause an increase of symptoms, really. It might do a little bit, but, you know, you just back off a little bit. So from here, if you've got like squares and you split it down to 5, we would normally say split one of the squares. Okay, so you literally just pull it and it will just peel the tape. Now you have two choices here. If I pull it all the way off, it means I've got to touch this end to hold it, and it means that I could take a layer off the acrylic. Okay, and I'll show you another way in a second, but I only tend to hold the end a little bit, and you apply that distal to where the pain is. So the pain's here, so we apply that first square, and we don't tend to have any stretch on that first square, because if I lay it down and then I pull it, it's going to cause like an irritation to where it attaches to. So we don't tend to have stretch at the beginning or the end, so a bit in the middle, if you're going to apply stretch, would be within that sort of component. So from here, it's awkward to try to peel this back now. So what you would do is lock it with 2 fingers, pull it, and it then causes it to lift. And then you can peel it back. So what I suggest with this one is we lock it and we apply 100% stretch, and then we back off to 50, and then we go anywhere between 50 and 75. Okay, I apply it to the area. Because it's not a muscle or tendon as such, it's more of a connective tissue, the plantar fascia, then this what seems to work better, yeah, where it requires a bit more stability. You know, it's like the low dye, it's quite firm taping. Whereas if you apply no stretch, okay, you're just laying it down, then I think it works better with a little bit of stretch. But then 50% stretch to ease off here, and no stretch at the end. Feed that out, blend it around the Achilles, blend it around the arch of the foot, pull a piece of tape, and then the idea is that the tape is heat activated for the acrylic, so it sticks better when it's a bit warmer. You'd be amazed when you take this tape off, say in an hour, trying to peel it off feels quite firm. Yeah,
I've
yeah.
never seen anybody do that before.
Yeah. So then I would heat activate it. You can use your hands if you want to. Yeah, so you can use your hands. The problem is your hands sometimes on a corner, sometimes you can call it to lift. Yeah, you can catch it. So that's part 1 done, and it's stuck very well to her foot. Yeah, around here. So the second one, I would normally go from the medial side to the lateral side. So the same again. So this time I'm not going to peel it off. I'm just going to peel it back. Okay, so I'm not going to contact the acrylic anymore. Okay, so I can apply that. I can stick that down just above the medial malleolus along here. So from there, I can pull that, peel it back to the first square, lock it down, and again 100, 50, 75, come round. And then as it comes to the lateral malleolus, ease off a little bit, okay, because it doesn't really affect the lateral side. Blend it around the bumps of the bones. And again, just for a couple of seconds, just heat activate. Now, if it didn't work, let's say for instance, can I have a stand and have a walk, please? Obviously, once you walk in, it's not going to restrict the motion. If, for instance, you know, like 2 or 3 days later, she said, no, I'm not really sure about the tape, feels a bit too tight, okay, because it might. Then next time, rather than applying more tension to it, I might go less, because Kenzo says sometimes less is best, okay? Rather than making it feel tight and restricted, you know, wrapping it round, almost like if you've got 75% stretch and it wasn't working, go to 50, okay? Go to 50%. Okay, and if that didn't work, go to 25. So rather than say, oh, let's go to maximum and make it feel as tight as we can. Okay, so Kenzo says less is best on there. Okay, so it doesn't restrict. It's not going to prevent the foot. No. And also, you know, you might, I don't know whether you do or not these days, but, you know, think about what's that sock called where you try to, the Strasbourg sock? Do you recommend that anymore or not? Yeah, is that out?
Sock?
Yeah?
The one that keeps your...
Yeah. Yeah.
Plantar fasciitis syndrome.
Why not?
Too difficult to speak with.
Yeah,
It's a
It doesn't do anything.
Actually,
Yeah.
plantar fasciitis is a weakness in the tissue. You lose weight, you need to strengthen the tissue, so not just stretching it.
It's also a problem when it's active, not lying.
But I'm sure some people on Amazon would be buying them.
Of course.
Yeah. But, you know, if you look at that type of device, okay, so the idea of this is that it's potentially just causing a microscopic lift whilst you were sleeping for a few days. Okay, so, and then they can take it off themselves. Yeah, and maybe 5 days later, it's not difficult. Yeah, to take off, things like that. You know, you can shower as normal. But, you know, it just is something like, you know, because people in where I was, you know, I teach all my staff and all that stuff. But people, like athletes in particular, will say, oh, I only want to have K-tip. I've seen it, you know, and I just want to try it. Okay, so, you know, whether they believe it's going to work or not, because they've asked for it and they've got the potential condition, yeah, because you've spent time and effort with that person applying, yeah, and talking about it, etc., then more than likely they're going to improve, whether it's a true healing mechanism from the tape or whether it's a placebo because they think it's doing them good. Okay, so it's yeah. Yeah. We do an ankle inversion sprain, okay? Inversion sprain. In fact, just thinking of a demo.
Actually did it.
As we say, this one's
I did
swollen.
3. Yeah.
Yeah,
I
will
don't
do
know
this
what's
one.
happened the last couple of days. I've actually did all 3. I broke all 3.
Yeah, I was looking
No,
at
that was
the,
out walking the dog. I went over a stone on the ground.
so she actually got a sprain in this one. You can see the swelling on the lateral malleolus. Yeah, on there. All ready? So what I've got now, so I'm going to show you, like in my book, this is a variation on what I'm showing you in there. So this would be, I don't need that one. So we've got, so this would be like a 7 in terms of a length, yeah, give or take. Sometimes I use a 6, but typically when we've sprained the ankle, what tendon attaches to the 5th metatarsal? Just you. Which one? The brevis, yeah? Yeah, so the peroneal brevis, okay? And then obviously the longest would come around the cuboid, yeah, and attach to the 1st met over here. So the 2 tendons can sometimes get like strained when you go over, and then you can even see gravitational bleeding, yeah, right up on that lateral side. Yeah, so when you're laying down, yeah, so when it's bleeding, no, bleeding is my accent, yeah. Yeah, so you'll see like bruising all the way down into the toes, all the usual stuff, or even like almost like mid sort of lateral sprain, yeah, or it can go right up to here. So that's why we might use a longer one, because we want to include the peronei rather than just stabilizing the ATFL and the CFL, yeah, around that sort of area. So when I do this one, when I was in the military, we would call this, we can almost get away with just using one strip, and they call it like a J strap. So when you are at, say, end point of rehab, but then the player is like, oh, I want to be taped, but I'm pretty good, I'm not really sure, then you could just, but then you've done this over a period, and you're sort of whittling him down or her down over the weeks, okay, and then they're almost there. But they're like, oh, I think I just need a little bit more stability. So rather than doing a full tape in everything, you can just do one strip. Yeah, and then you can change the tension on it, like 100%, 75%, 50%, no stretch. But you might not tell them there's no stretch. Okay, so you just slowly just whittling it down. Yeah. So what we're going to do is do 2. So we're going to spread it over, and that will be 7.5 centimeter rather than all the way for 10 centimeter. Okay, so we overlap. So we'll cover the ATFL and the CFL. And it works really well, okay? So what we're going to do is, with a foot, we don't tend to start with it preloaded like an inversion, because that's how you sprain it. So we'd almost want to be more into dorsal eversion, almost not neutral, but into an everted position, because we want to like stabilize the lateral side here, okay? So we want to almost prevent her from going back over, okay? So we can start in that sort of position here. So first one, we're going to go above the medial malleolus, okay? But we're going to go slightly anterior. Not very matters. You can go anterior or posterior. So anterior of, you'll see why. So pull and peel to the 1st square. Now from there, now if you watch this one now, so if I lock it down and go all the way, so it's 100% stretch. So from there, so I go anterior all the way around, okay? And then this one is going to, if I just turn the leg slightly that way, okay, this one is going to cover more the ATFL, okay, from there. And I've put in 100% stretch, so I've given maximum stability to that anterior. Yeah, okay, so it's anterior of the malleolus. So you can probably guess now the second one, if I wanted to include the CFL, is going to overlap, okay, and is going to go posterior, pull, from there, 100% stretch. Try not to get twist underneath. It doesn't really matter if you get a twist on the side, because you're not going to, it's not going to cause too much of a problem. And then stick that down, 100% stretch. blend it. Be careful because they might be pretty tender if they've sprained it. You potentially could do this in an acute ankle because you're not wrapping around it.
Oh, right, yeah, okay.
Okay? Okay, so you're not causing a compression around. You wouldn't want to be wrapping. A friend of mine, he's not around anymore, but he would use like a bubble wrap. Sounds a bit weird. So like the bubble wrap that comes around like a TV and things like that. So he cuts a bit of that out, okay? And then that's amazing because he puts it around an ankle, puts a little bit of tape, and it gives you compression and a bit of protection at the same time. Yeah, yeah. So with this, and he looked after Morecambe. Yeah. Yeah, Morecambe Football Club. So he only wanted a little bit of protection, and it just seemed to work quite well for him. So that's.
Did you ever use the thicker tape rather than using the whiter tape?
No, because it's too wide. Yeah, yeah. So it's 10 centimeter. They do a rock tip. It's called the Big Daddy, but it's too wide. So I would normally use 2 strips, and then that in itself would give you some support on that lateral side. Okay. Now, if you wanted to take it to another stage, then you can either use freeze. I think because you've got a sprain, I might have to do a 4 for on. I'll use a rock tip one this one. So if I do a 1. It depends on the size of the ankle, so you have to, for some it's a 3, for some it's a 4. So if I've got, say, 2 4s, so with this one, if you bring your foot a little bit towards me, bring your foot up a bit. So we're going to come around anterior part of the joint line. Okay, so with this one, we're going to do 2 there. So start around there, the anterior joint, pull. And with this one, about 50% stretch, come around. But I need a bit more for you. I'm going to do a bit more. I'm going to change that one.
So can I ask, like, why? So what if we started in dorsiflexion for taking the plantar fascia and things?
Yeah.
So we're coming to the last lancet break. Why are we not inverting, or are we inverting the foot?
We don't want to tape an inversion because we don't want to tape into injury.
Okay.
Whereas this is, in terms of K-tip, this would be an exception to the rule. Because most K-tip, like 80% of K-tipping, we would preload, so we would preload the tissue. But because we got an ankle inversion sprain, we can't preload the tissue into inversion to tape because we tape it into an injury. So we might make it more susceptible to pulling it in. Does that answer the question? So we have to tape out to stabilize it. So it is an exception to the K-tip rules, if you like. Okay, so this would be a bit wider, yeah, to cover the malleolus in here. So it's normally like a 3 to 5. Let me just show you again. Let's go that. So pull. Come around. That's what I mean. So I quite like it when you have to adapt it rather than just using this sort of like standard size tape. So for pull back, so 50% stretch. Come round. Just above the ATFL. The first one. So still we're not contacting. Okay, so again for an acute ankle it would be okay. Because there's a gap in between. And then from there. And then this covers CFL and the lower part of the ATFL. Around there.
How long would you leave it on?
I'd still leave it on for days, a few days. I'd say leave it on as long as they comfortably can. But they can ice over this. You can ice over it, yeah, because it's only cotton based. Okay, so they can put ice packs over this. Yeah. Just have a stand, have a walk, and just see what you think. Yeah. Right. If you go up a little bit more, that's okay. Yeah, because he's taller. If you bring the foot up a little bit like this, okay. So, how long have you had this?
This one, about 18 months.
It's not so.
This one at the moment is a little bit higher. It's coming around to coming up towards the tendon.
What, right up here?
Yeah.
I say I don't feel that much in here.
It's mainly just feeling it when I'm actually actively pushing it.
Yeah. Okay. What's your sport? Running. Hmm.
I might just up my activity level a little bit too quick.
Any pain, sort of like posterior calcaneus, even like fat pad area. We mentioned the fasciitis, yeah, calcaneal. You know the name is the potentially severs there. Yeah, but anything like retrocalcaneal bursa, yeah, around here. You can call it other things like a periosteitis, or some call it like an insertionitis. Some call it periosteitis. There's lots of different names. Okay, yeah, basically, you know, where the tendon attaches to the bone, the periosteum, etc. Around here, any sort of like thickening within the Achilles, you know, if you're like a tendinosis or tendinitis or a para or peri, sort of like, so it doesn't really matter. Okay, yeah, so this one works quite well. You could potentially drift up towards the MTJ, the muscle tendon junction area, because the tape is a bit longer. So it is going to go up here. When it was taught to me by Muller, they would use 2 fingers, but these 2 fingers would go towards the lateral and medial head of the gastrocnemius on the posterior part of the femur in here. But on cyclists, they would irritate the back of the knee. On a runner, it would be okay. So I've modified it so we almost like finish, so like mid gastrocnemius. Okay, and it just seems to be better rather than continuing all the way up here. Yeah. Right, so the first one is a bit longer, so it's up to you what you use, maybe a 7 or an 8, maybe even a 6 from here. Split the first square, apply that directly over the calcaneal area here, like that. Now, pull it and peel it back. Right. If I lay that down with no stretch, the corner here is going to crease. So if I apply just marginal stretch, say like 5%, it takes out those creases in the corner here. Okay, so just a little bit, but not much. This works very well for triathletes. Yeah, because obviously they got to run and they got to go into water. Yeah, it doesn't matter if it's like seawater or seawater or fresh water. Then it works very well. And men with hair, with a K-tip, it's okay, as you see in a second. But if he was my patient, and it's not so bad, but potentially I would trim it a little bit. Okay, don't shave it, just trim it. You know the trimmers? Yeah, like maybe like a 4. Okay, just bring his hair, yeah.
I don't mind trying just now. Don't we, Mike?
Yeah.
Let's do it. Hold on.
With the scissors.
Give him a minute. That's fine, Michael. How's
Okay.
that?
Yeah.
That look. I'm
Yeah.
having such a good time.
There you go, see? There you go, there you go. Yeah, yeah, no, like, it's interesting because my osteopath, we run like a drop-in clinic every twice a week in Oxford. It's finished now, and every time I can hear my my osteopath with a, you know, like he's like a next one. I was thinking maybe, you know, shouldn't be a hygienic perspective, just but anyway.
Using the same shaver.
Of course. Yeah, I know. Yeah, but you know, athlete, 21-year-old athlete at Oxford, they're not paying any money. It was just like, just get on with it. Sorry. So from here, a little bit of stretch, but not much. Okay, and then from there, 2 fingers or your hand, just glide it straight up. No stretch yet. And because you've got hair, you want to really just heat activate it. I'm joking. So when it comes off, it won't be the most comfortable. And now, because you stretch it a little bit, there's no creases on that sort of corner. Yeah, just on that area there. That would be okay in itself. If you're rushing for time, then that would be fine. You know what I mean? So if you've got like a few athletes you're looking after, and you're like, you know, by the time you've done 3 bits of tape and do this and do that, time's gone. Whereas in this one, if you've got a few strips, you can just do, yeah, next one, yeah, next one, and so on. That's the first one done. So if you want to add another 2 bits to it, so each finger, so we cut to the first square, we round each end off as well, and then we split each finger so they are separate. Okay, and then apply this tape over the first one. And because we've already pre-stretched his Achilles and his calf, so when he's walking, let's say he wanted to run, it's not going to restrict the movement. If I taped him in plantar flexion and asked him to walk and run, he'd be like, wow, that's pretty tight. And you want me to run? I got no chance. So from here, so the first finger, 50 to 75%. Okay, so it's 100, 50, 75, blend it around, and I tend to finish around the middle, like this. And then the second tape, Same again. Okay, so 100, 50, 75, blend it. And then this one tends to cross the first one and blend in perfectly like that. Heat activate from there. Now, with this one, it depends where the symptoms are, because remember, these are symptoms. It's not, K-tape doesn't really treat cause ever. Okay, yeah, so where does it hurt? We tape. Where does it hurt? We tape. So, there's many reasons why you have symptoms, but it never really treats, treat the lower back, but you're only putting tape over the lower back. It's not treating the disc pathology and, and why did you get in the first place and things like this. Yeah. So where the pain is, I know we said it's more up here, so we could put one directly over, but if he's got a true Achilles issue, then this would be directly over the Achilles. So with this one, we split it like a plaster. Peel it back. And like SJ was saying earlier, you could with a plantar fascia come up under tension, come right underneath it, and off you go onto it. Same with this one. So pull it either side, 100, yeah, 50. Okay, so 50 to 75, directly where the pain is. So this would be known, stick one side down, do the same on the other side. And then those two sort of like lugs, you just blend over. 1,
So the
2.
tension's in the middle there.
So the tension's in the middle because it decompresses. Levo tape, which is an Irish company, would call it the pain relieving strip. So we tension. So when you let go, it causes a recoil. So it causes like a lifting effect directly to it.
Just in the t-shirt the other side, you can see
Yeah,
that.
yeah. But you won't see anything here. You won't see any coiling effect of it. But if I tension this t-shirt and put a piece here and let go and look under, you'll see it's, yeah.
It's a bit like an iron, hot iron.
Yes. Yeah. Have a walk around, please. Just see how it feels.
So what
Good.
tension was your first case?
No tension.
No tension.
50 to 75, and third one 50 to 75. Remember, it's all written down for you, and the QR code is in there. Yeah.
It's in the notes, like into that.
Yeah. Could you run with that? Yeah. That's what I mean, because the athlete will want to run, will want to do something, will want to. Okay. Yeah.
So you keep them. And you're there, oh God, yeah.
Yeah. So it's not, it's not restrictive taping. Whereas if you taped him athletic taping, and you wanted him to go into the water, he'd be ripping it off.
No, you,
Okay.
you must just, it must take your mind off the game as well a lot, but when you've got the rigid taping on compared to what that is.
Yeah. Yeah, so it seems to work. There is place for the athletic taping if you want to truly restrict it. Okay, but in terms of, like a niggly sort of Achilles and niggly gastroc, but he's still active and he's still playing, training, okay, then this probably has its place. Cool. You want to have a go? Yeah, and then we, yeah, that's just a ligament. Yeah. It's normal. Do you want to have a go at that one? And we're probably not far off then. Hmm? Yeah.
Yeah, you going to Rocky Hall on Saturday?
Yeah,
Which one?
right.
Which
Sorry.
one? Yeah, you've got one.
What's this?
Yeah, and then,
You going there?
yeah.
What is what?
You're not getting dressed up, are you?
Rocky Horror?
We would like to get something together.
No idea.
Oh, I have no,
Yeah. Interesting.
Feel like Inversion was games I'm looking forward to them.
Yeah. Yeah. I've been to the Rocky Horror. It's fun. Yeah.
And then 13 inch. That's,
Yeah.
This is from the last Rocky Horror.
Yeah.
Back in the.
Jump to the left, is it? That one? Jump to the left.
left. It's still only just
The music.
Now, Gene, I was going to get dressed up first, but we were gone before it got cancelled, but I'm not going to get dressed up on February. No.
Got two Frankie Burners, and then we've also got an Eddie.
Then he was going to go, my hubby was going to go as Rocky. I was going to have a sign on his back that said retired Rocky. Because he's got a keg, he hasn't got a six-pack.
Just have to get him a muscle suit.
Wait, you got it. I mean, but him, he's hot. No, forget it.
This will be the last one, I think. Isn't it? 7. You can do like a 7. Yeah.
Actually, this one's probably close to my Achilles. I'm just dyslexic and I can't tell you which one's. This was the original injury, and then I tweaked my lateral head of the gastroc on this one. taking selfies though, Sophie?
No?
No, I'm taking pictures. When do I take selfies?
Quite often.
When?
I
Shall
do.
we get your Facebook?
Sorry?
Shall we get your Facebook?
I have a bad reputation.
Oh, it's fine.
Like I say, it's not a bad reputation, it's just a reflection of the truth.
That's it. Good.
I'm about wrong.
Yeah, but that size probably on that tape would have been that length there. Yeah. But for some, it's okay, that. That's all right.
And the more
What's quite nice with this tape is you can almost like feel any imperfections within the Achilles, you can almost like feel it quite easily. Yeah, you could, yeah, you can almost see it like a thickening. Yeah.
That's for Michael.
Yeah, that is then.
Yes, that's her. That's her. You should that's her. Look at that. That's her, Michael.
So just go a bit lower. It's a little bit lower.
What if you got this tape, then the worse it gets to come off, Michael.
If you stood that side,
Uh-huh.
yeah, you might find it easier to glide and maybe swap hands. Yeah.
Oh, like
Yeah.
that. Yes, I'm holding it
Yeah.
over.
And then as you, so no stretch, and then use your, like a little bit of tension on it, and then just like use your fingers and glide it up, and then no stretch, just feed it out. Blend it around the Achilles. That's it. And then use your hand and heat activate it now. That's it. Well done. Sometimes it's easier from the side just to do it.
Yes, actually,
Mm.
it probably is. And this one.
Yeah, rather than doing it like that, because it'll take ages, just pull one finger and then do the other finger so they're separate. Yeah? So you just try. That's it. And then you can just peel that back in. And then that goes over the first one. Yeah.
Are you wanting one?
I'm not going to open that. I'm going to show you.
And these came
Yeah,
up.
so they go lateral. Well, it's actually medial to the side, doesn't matter. Okay,
Yeah,
and then 50 to 75%, so it's going to finish about here.
The ones you had,
Yeah.
the ones you get about.
That's why it's quite nice to mix the colour.
Yeah,
so,
I realised that once I did it, I was like,
Yeah.
oh, this is all great.
yeah, rather than trying to, yeah, that's fine. Because I normally would peel it. Mind you, that looks quite nice. I like that colour. And then finish and just
I like
overlap
this
it.
colour as well.
Yeah, so they blend in together. Yeah, so it's almost like they're one then, see? Yeah. And the third one, just where if you've got any thickening on the Achilles, you know, that's why you've come to see. It's a little bit just now. And that would go directly across it.
That's quite long though, actually, for that. Or is
That'll be
it?
okay.
That's okay. I'm not rounded the end, so I need to get up scissors.
So you do one at a time.
I was
Yeah.
just holding the heel back.
Okay, sorry.
No, it's okay. And then, now which one
It
did
doesn't
you
matter.
do first?
Makes no difference. Yeah. So you pull it so it peels it. Yeah, I see. And then peel it back. Yeah. And then feed it on the edge, and then that's going to finish in the middle over here. Yeah. And then the second one then will blend in together, so they look like they blend as one.
Oh, lovely. Really like that combination.
What colours does it come in?
There's a choice of loads. There's loads.
I mainly just use the
Yeah.
black.
I like the military one, huh?
You mean you don't have blue and green just for the.
Do you like them? I've never bought them actually.
Yeah. The camouflage one they got.
Yeah. I think.
Yeah, no, there's so many different variations. Whereas most people just, most companies have like blue, black, pink, and beige. Yeah, like if we look at the Chinese ones, they're just one of, sometimes they're orange, yellow.
Oh, you
Yeah.
didn't colour this.
No, nothing.
It's nothing. They're all the same.
No. Now you could have your own tip branded with rock tip, but you'd have to buy 500 rolls minimum. Yeah. Well, that's what they used to do.
No, don't tell me. Don't tell me.
Okay. The middle.
Yeah. Don't tell me.
Okay.
Yes, yes. Bite your tongue. Okay.
Good.
I forgot It was on.
See how tight
There
it
we
is.
go.
Ah, see, good.
See how tight it is.
Patients, people was finding
Are
that
you- the doctor
it was
said
starting to
that.
peel. If they put a
Me?
bit,
They could.
that wouldn't affect, that
No.
wouldn't affect the use of it,
No, that'd be okay. A lot of people might put a little bit over where it's peeling.
just to keep it on.
Yeah.
It doesn't affect
No.
anything of it.
No, not there, because
No,
it's
they did
working.
it
Yeah,
there, it would, but
Yeah.
not in the corners.
Yeah.
Well, that's good.
yeah, that's okay. Yeah.
Right.
Yeah.
No, that's fine.
Or they can
That's
peel it
fine.
back a bit and just trim it and then stick it down. That should work.
That's fine. I'm just trying to work out how you keep it going. If it was, what would affect it, what wouldn't.
Yeah, looks good. Good.
So how does that feel, Michael?
Good.
Lovely.